Now we have discussed the musculoskeletal diseases and the neurologic diseases, which are the two main categories of the chronic orofacial pain. It's time to talk about the vascular diseases. We're going to discuss migraine, cluster headache, tension headache, and we will know how to differentiate between these three types of headaches. Then we are going to study the temporal or giant cell arteritis. Migraine. Migraine is a recurrent headache that may last for hours or 2 to 3 days. It's due to arterial dilatation. The attacks are precipitated by alcohols, drugs as nitroglycerin, stress and environmental factors as smoke and noise. It may be triggered also by foods such as nuts, chocolate, and red wine. Stress, sleep deprivation, or hunger may also precipitate migraine. It's characterized by unilateral throbbing or pulsatile headache pain. Phonophobia and photophobia may be found. Nausea and vomiting may occur, and they are sometimes preceded by visual or sensory aura. It's treated by drugs and avoidance of precipitating factors. The migraine headache is common before puberty in females more than males. Aura may be developed before headache in 40% of patients. The headache is intense, severe, and unilateral. Each attack may last for several hours or days. The cause of migraine has generally been attributed to instability of the cranial arteries. Treatment is done by avoiding trigger factors. Acute attacks should be treated by analgesics and sumatriptan, also ergotamine. Prophylaxis by propranolol and calcium channel blockers and tricyclic antidepressants. Cluster headache. Cluster headache is strictly unilateral head pain. Pain is severe, sudden and burning. It's centered around the eye and temporal regions. The pain is episodic, may last from 15 minutes up to 2 hours. Can be several attacks per day. It occurs mainly in young male patients. Majority of the painful episodes occur at night, often awaking the patient from sleep, like an alarm clock. May involve one side of the face from the neck to the temple. %80 of cluster headache are men. The attacks are sudden, unilateral, and stabbing, causing the patient to cry out and even strike objects. Some patients exhibit violent behavior during attacks. Pain was described as a hot metal rod in or around the eye. Each attack lasts from 15 minutes to hours and recurs several times daily. The pain of cluster headache is associated with nasal congestion and tearing, sweating of the face, ptosis, increased salivation, and edema of the eyelid. Cluster headache produces pain in the posterior maxilla that mimics dental pain. It's triggered by alcohol or coffee. This diagram summarizes the clinical symptoms: ptosis, meiosis, and reddening of the eye. There is lacrimation, rhinorrhea from the nose. Pain is in or around the eye, like a metal rod. Cluster headaches may involve pain around one eye, along with drooping of the lid, tearing, and congestion on the same side as the pain. Prophylaxis of cluster headache or migrainous neuralgia is done with ergotamine, prophylactic, prednisone, and calcium channel blockers. Treatment of acute attacks of cluster headache is done with 100% oxygen. This is also a diagnostic method, in addition to injection of sumatriptan or sublingual or inhaled ergotamine. Tension headache. Tension headache is characterized that it is bilateral, not unilateral. It's mild to moderate feeling of tightness, constriction, or pressure. It occurs in the frontal, occipital, and temporal muscles, may be episodic or chronic. It's not accompanied by systemic disturbances or neurological signs. So, if you want to compare between these four types of pain, we can note that the sinus pain lies behind the brow bone and the cheekbones, where this is the site of the sinuses. But the cluster headache is pain in or around one eye, with lacrimation, rhinorrhea, dropping of the blood. So it is localized in or around one eye, only unilateral. Tension headache is bilateral. It's like a band squeezing the head. The migraine is followed by or preceded with nausea, visual changes, or typical for the classic form of the migraine. And of course, it's unilateral. Again, the cluster headache is pain which is often around eyes, and patient may wake up in the middle of the night screaming of pain. The tension headache may occur once or few times a week, or may be continuous for several days. It's bilateral, like a squeezing band, occurs in the frontal parietal muscles. The migraine is unilateral, severe, intense throbbing pain. This throbbing pain with pulsating character and most localized on one side of the head. Temporal or giant cell arthritis. Generally, giant cell arthritis is an immunologically mediated disease. It's characterized by inflammation of the wall of medium-sized arteries with prominent giant cells. There is obliteration of the artery lumen and ischemia of the part supplied by the involved artery. Giant cell arthritis may affect the craniofacial region. For example, the temporal arthritis, the inferior alveolar arthritis, the lingual arthritis, and so on. So, giant cell arthritis is an inflammation of the cranial arterial tree that can affect any or all vessels of the aortic arch and its branches. It's common in patients above 50 years old. It is secondary to giant cell granulomatous reaction. Temporal arthritis is an inflammation of cranial artery tree secondary to giant cell granulomatous reaction. Clinical features most frequently affects adults above the age of 50 years, unilateral or bilateral, dull aching or deep throbbing temporal pain of acute onset over the temporal region with prominent tortuous tender temporal artery. It's accompanied by generalized symptoms including fever, malaise, and loss of appetite. Pain in the jaw during mastication occurs, and pain may also radiate to the mandible or maxilla. Diagnosis can be done by making hematological tests. You will find that there is elevated ESR, erythrocyte sedimentation rate, elevated C-reactive protein, the CRP, and when taking biopsy from the artery, you can make definitive diagnosis. Treatment can be done using high dose of corticosteroids. The steroid is tapered once the signs of the disease are controlled. Patients are maintained on systemic steroids for 1 to 2 years after symptoms resolve. You can see here the prominent temporal artery with its tortuous course, common in old age patients or patients above 50 years old. All psychogenic disorders are characterized by 4 clinical features. When examining the patient, there is no obvious underlying organic sign of any disease. Pain doesn't awake the patient from sleeping. Pain doesn't follow anatomical pattern and may be bilateral. Simple analgesics are usually ineffective. The diagnosis of all psychogenic diseases is done by exclusion of other causes of orofacial pain, after taking case history and doing proper clinical examination, sometimes using diagnostic aids, and vitality tests and radiographs, with thorough examination of nose and pharynx and complete oral examination, as well as careful examination of cranial nerves and parotid gland. Burning mouth syndrome. Burning mouth syndrome occurs for 5 persons per 100,000 persons. It has high incidence in middle-aged and elderly-aged patients, especially postmenopausal females. The cause is unknown, but hormonal factors and stress have been implicated. Patients of burning mouth syndrome complains of burning or aching sensation in all or part of the oral cavity. It may be bilateral. The tongue is the most frequently involved site. Dry mouth and altered taste, which may be aggravated by certain food, is one of the patient complaints. Pain doesn't awake the patient, as we said before. Investigations for burning mouth syndrome is important to do complete blood picture, hematinic tests, including RBCs, iron level. Swab for Candida can be done. Treatment of burning mouth syndrome includes reassurance, avoidance of stimulating factors, tricycling antidepressants may alleviate the pain for some patients, topical clonazepam, which may be sucked or spitted, 1 mg 3 times daily for 2 weeks, 2 months course of 600 mg daily alpha-lipoic acid with cognitive behavior therapy. Atypical facial pain. It's a persistent facial pain that doesn't have the characteristics of neuralgias and is not associated with physical signs. It's confined at onset to a limited area on one side of the face and may spread to the upper and lower jaws or other areas of the face or neck. Pain is present daily and may persist most of the day. The constant dull aching pain is deep and diffuse. It's poorly localized, with variable intensity. And as we said before, all psychogenic diseases are characterized by absence of identifiable organic disease. It's more common in females also, and most patients are middle-aged and elderly, like all psychogenic diseases. Atypical facial pain is characterized by continuous dull ache, which is bilateral or unilateral and frequently affects the maxilla. It's often difficult for patients to describe their pain. History of restoration or surgical treatment to resolve the pain is common, because the patient has usually visited many dentists. Frequently, the patient has been seen by several specialists. Atypical facial pain often is initiated or exacerbated by dental treatment. Dry mouth and chronic pain syndrome are one of the symptoms or complaints of the patient. The common site is maxilla and tongue. It responds poorly to analgesics. Emotional breakdown and tears, hysteria are common. Treatment of atypical facial pain includes tricyclic antidepressant drugs, which have some effect in some patients. 30% of patients respond to gabapentin. Cognitive behavior therapy or psychotherapy is recommended. Atypical odontalgia. Like the other psychogenic diseases, it occurs more in women or females, 4th or 5th decade. It's constant dull aching pain without an apparent cause. This means absence of any identifiable organic disease. It occurs after dental extraction or endodontic treatment. There is a toothache, but there is no detectable cause. Pain is unaffected by endodontic therapy or even extraction. Pain is persistent in a single tooth or a group of teeth that exhibits no abnormality on percussion or pulp testing. Management of odontalgia or phantom tooth pain includes patient reassurance and consultation to other specialty. Tricyclic antidepressants like amitriptyline or nortriptyline at low dose, 10 to 25 mg at night. I hope you get benefit of this lecture. Best wishes in your exams. Thank you.